So good morning to everyone here in London. Good morning to everyone on the video conferencing. Good morning to everyone on the phone, and good morning to people on the video. So I'm going to, the title of the presentation is the reading pack for health responses to humanitarian crises, and a humanitarian overview from principles to coordination, which I thought was a bit boring and a bit of a mouthful, so I'm calling it snakes and ladders. So what I'm going to do is take you through the snakes and ladders that we actually see in humanitarian crises. And so if we're actually wanting to achieve the development goals in many of the contexts that we have, the potential snakes that we see in these contexts and the threats, and the ladders, the opportunities that we have in these contexts to achieve the maximum public health and development goals. So I'm going to, just to bring the analogy on, I'm going to talk about the different types of snakes that we have in these contexts, and the different types of crises and the impact, the deadliness, as it were, of the different snakes, of the threats that we see. The lengths of the snakes, how do we measure a crisis, assessment and monitoring. How do we reduce the length of a snake, or how do we miss a snake altogether? And health resilience, how do we overcome and mitigate the impact of threats to public health? How do we kill a snake? How do we respond to a crisis? How do we climb up a ladder? What are the opportunities that arise from crises? And a bit of guidance on ladder climbing and snake killing, which are the resources that are available. So apologies, the analogy will start to stop, so people, I think we'll just get a little bit fed up with it after a while, but that is what I'm going to be covering. So why is this important? Isn't this just a small thing? Humanitarian crisis, it's a minority of things. Why is this thing important to us in DfID? Well, actually, if we look at the literature, 60% of preventable maternal deaths, 53% of under 5 deaths, and 45% of neonatal deaths take place in fragile settings of conflict, displacement, and natural disaster. So if we're ever going to stand a chance of reaching our development goals, we have to address the challenge that's set to us in these settings. We can't avoid it. And we will continue to see, as we go in the decades to come, we'll continue to see a widening gap between countries that progress towards the MDGs. We see them developing, we see the indicators reducing, the maternal mortality, the infant mortality, the neonatal mortality reducing. And we'll see these countries which stagnate, these countries, the fragile states that just fail to progress. And one of the things that I think we'll see is just this increasing gap. These contexts that are left behind are more likely to experience shocks. And they've also got the least evidence for knowing how to address this. And they've also got the least capacity for being able to address this. And if you want to know more about it, there was an article in The Lancet in May 2015 by Zede, which was For Every Woman, Every Child, Everywhere, a universal agenda for the health of women, child and adolescents, which outlines the literature on this. And in DfID and across the global public health spectrum, following the Ebola crisis, we've seen a lot of focus on outbreaks. And this is quite right, they are a global public health threat, and we saw in Ebola the magnitude of the public health threat that they can pose to us. But they are not everything. They're not necessarily going to be the next crisis, and they are certainly not the thing that's the major contributor to the 60% of preventable maternal deaths, 53% of under 5 deaths, and 45% of neonatal deaths that are occurring in these contexts. So if we actually want to address the challenges that we're seeing in these protracted humanitarian crises, it's not all going to be about outbreaks. We have to have a much wider focus to address the major challenges that are occurring in these contexts. So what are the impacts of these different types of crises? Well, it's very dependent. It's not specific. It depends on the type of crisis, whether it's conflict, whether it's population displacement, whether it's outbreak, whether it's natural disaster, whether it's famine. It is very dependent on that. And often in these contexts, we're often seeing multiple types of crises. In the 4 years I spent in South Sudan, we experienced floods, we experienced conflict, we experienced economic crisis, we experienced outbreaks, we experienced famine, we experienced nutrition crises, we experienced political crises. these countries, which are the countries which are the most likely to fail to progress, will not experience one type of crisis. One of the things we can predict is the unpredictable. They'll experience regular crises throughout different types of crises over the next few years. It's also dependent on the strength and the resilience of the pre-existing health system and services. And we had a lot of talk about that following the Ebola crisis. And it's also dependent, obviously, on all the pre-existing health problems in the country. We're not going to get malaria in a crisis in a country which doesn't have malaria. So these are all, it is very dependent on these. But we can predict some of the major trends in these countries. And we can also look at what are the immediate, the short-term, and the longer-term impact of these regular crises. And they can be protracted, they can be rapid onset, they can be slow onset, or they can be an outbreak. But they're often in these contexts, it's what I would call acute on chronic, where we have a chronic crisis, which is weakening the system and causing all of the health indicators to stagnate. But then what we do is we have the short-term impact, in a way, the snake, of a rapid onset, whether that's a conflict or whether that's an outbreak, whether it's a health system collapse. And that just puts everyone back. It puts you back a few spaces as you're trying to develop. So you do get a short-term impact of these crises. So I'm just showing the next slide, which is the impact of varying types of crisis. So this is from the Sphere Handbook. I'm not going to go through it, but it does give you an indication that depending on whether it's a complex emergency, an earthquake, high winds or flooding, you can give some generalizability about how many deaths, mortality, communicable diseases, food scarcity and population displacement. So we can have a general idea which is available in the Sphere Handbook. But common things, like we say in medicine, common things occur commonly. And actually it's not the unusual things that generally are the major causes of mortality in crises. It's not the Ebola, it's not the viral hemorrhagic fevers, it's the common things. The major causes of death in children are still pneumonia, diarrhea and malaria. But actually what happens is these common, and maternal mortality, well, what happens in crisis is these common causes, the most common causes of mortality, increase. And why do they increase? Well, they increase due to change of behaviour. For example, following the Haiti earthquake, women stopped breastfeeding because they felt that their breast milk had been shaken up. It leads to disruption, massive disruption in health services and health systems and other broader public health services as well. People have reduced access to health services, often due to humanitarian and protection issues. There are environmental factors, maybe flooding or reduced access to clean water and sanitation. And there's often, in these crises, there's frequently overcrowding and shelter issues, which can cause, with a poor shelter, can lead to respiratory disease. With overcrowding, can lead to increased likely for there to be outbreaks. And then high exposure to disease vectors. People won't necessarily have travelled, if they've been displaced, they won't necessarily travel with their mosquito net. And they'll often be in much less stable infrastructure in their shelter. And insufficient vaccination coverage. Often what will happen is we will see many of these countries have a very low immunisation coverage to start with. We're seeing Angola with the yellow fever outbreak at the moment, which had before the outbreak had a yellow fever coverage of about 30%. But often in these countries, there's the following shock. So for example in Syria, it's very difficult to get vaccination coverage out to the most difficult areas. So it actually makes these pre-existing coverages worse. But there are also, these are the predictable, these are the things that we can always say they're going to occur in crises. There's also things that increase with specific emergencies. So for example, we have the communicable disease outbreaks like cholera and diarrhea from flooding and drought. Flooding because there's contamination of the water supplies, drought because people go to unsafe sources of drinking water. Measles outbreaks as a result of overcrowding if you've got a low measles coverage. Injury from natural disaster. Exposure to violence and other traumatic events, such as gender-based violence, increasing with relation to crises. And some of the statistics show that women and children are 14 times more likely to die than men in a disaster. And we do see increased maternal and neonatal mortality due to decreased access to reproductive health services. These aren't because people start having more babies in a crisis. That only occurs 9 months after a football match. What we see is it's because people have less access to services, and there's sort of disruption in their services, which is why people are more likely to die from these conditions. So this is my weather forecaster map. I'm just going to stand up to show this, but I'm going to try and describe it on the phone. What we see to start with is, and I will be a bit of a weather forecaster, over here to the left we see the black line, which is the sort of the direct impact of the shock. So, for example, following this is a classic diagram, an indicative diagram following rapid onset crisis. And the black line shows the direct causes of the crisis. So, for example, this might be death and injury after an earthquake or a tsunami. So this will happen. And often what will happen is the media, and there'll be a lot of media and political attention on this cause, on this direct cause. You'll get surgical teams flying into the crisis to deal with this cause. But actually what we find is this cause diminishes after a week or so. Often we no longer require surgical teams after a natural disaster after about 3 weeks. But there's often still, at this time, 3 weeks later, often you'll see surgical teams still flying in for our medical teams. Then there's this yellow line, this dotted yellow line, which is the post-disaster epidemic. Is there a strong association between epidemics and crises? My personal feeling is we have seen circumstances where we've seen epidemics cause humanitarian crises, such as the cholera in Zimbabwe and the Ebola in West Africa. And we've also seen situations where humanitarian crises have led to epidemics, such as cholera in Haiti. But I think it's very much dependent on the circumstances specific to the crisis. So almost a crisis, if you get more displacement, if you get poorer water and sanitation coverage, if you have low immunization coverage, it's more likely to occur, to result in an epidemic. But then what happens next? This is the next bit of the graph, is where you see the regular problems occurring. So first, after a couple of weeks, we're very likely to see increased waterborne diseases, so increased diarrhea. And that's likely to become a sort of major cause of morbidity and mortality a week or two into the crisis. And then maybe a month into the crisis, we'll see increased vector-borne diseases and morbidity and mortality from things like malaria. And then later on, maybe a month or two, we'll see the green line, which is acute respiratory disease. And so this is just a generalization, and it's an indication of what we've seen regularly happening in humanitarian crises. And then the red line, the blue line was acute respiratory disease. The red line is what we see is the psychosocial. In psychosocial, we do see people experiencing what is often described as trauma following a crisis. But actually, for the majority of people, this is a short-lived thing and will tend to stop. We have reactions, we have acute grief reactions, and this is normal. It's a normal part of our behaviour. But for some people, we will see increased mental health problems in the longer term. And crises do present an opportunity for developing mental health systems and services in countries. So I'm going to look at the impact of crisis on health systems. And this is from a systematic literature review of what happens regularly to health systems in crises. And we see none of it is particularly surprising. We see a breakdown of systems and institutional mechanisms. We see a damage to infrastructure, which can sometimes have decimating impact on the health system. The photograph on the top of this slide is of the Ministry of Health in Haiti, which, if you imagine, this had many of the Ministry of Health died following the earthquake in Haiti, and they had a paper-based health information system, so it led to complete disruption in their health information system. Generally in crises, we see less horizontal and more vertical programs. People want to do something specific. People want to do a vaccination campaign. People want to invest in water and sanitation. They don't want to invest in public health more generally, and that causes us problems. And we need to be aware of that as a funder. It can exacerbate inequities within the country, so that often the more deprived areas will get even further deprived, even more vulnerable, except for specific pockets where the humanitarian community identifies it as a particular priority, and then actually you might get increased services to that pocket. But generally you'll get increased vulnerability. Plethora of organisations, multiple NGOs and foreign medical teams, army, private sector coming into the country, which the government and the health system have to deal with. The impact on the health workforce, often you see death and migration. In many of the crises in the past few years, we've seen targeting of health workers, and MSF and ICRC have been doing a lot of work looking at how to mitigate the impact on health workers and the targeting of health workers in conflict. Reduced domestic health budgets, increased funding often for military, but we also see increased external funding and the dynamics that brings to the context. And large quantities of sometimes inappropriate donated supplies. I've often been to a warehouse and seen a warehouse full of completely unnecessary medicines and injectables that were discarded, all well-meaning, but it produces a burden on the health system rather than an opportunity. Decreased supply of medical commodities, increased different supply chains, a lack of health information, so we get less information because there's so much confusion, particularly early on in the crisis. But we also see a proliferation of guidelines. Everyone brings in their guideline, and so we get an absence of evidence, an absence of information, but lots of guidelines on how to deal with it, which causes problems and confusion. And sometimes we'll see hospital care expanding at the expense of primary health care, with referral systems crumbling. And the reason for that is often a hospital care system is much easier. For some funders, it seems much more tangible to sort of send in big, large tented hospitals and that type of thing. So actually, need to be aware of these all potential impacts in order to mitigate them. So we can assess the problem, we can measure the length of the snake, and there are different times, and we need to look at the different types of assessments we use at the different periods. And there's something called the MIRA, MIRA, which is the multi-sector initial rapid assessment, and the interagency rapid assessment, and it describes an initial assessment, such in the first 72 hours, which is a very rapid risk assessment. It's quick and dirty. It's what immediate information is available. You use existing data sources. We don't do a large population sample. Often, an assessment can involve driving around the area and observation. It can look at the existing data sources. What were the pre-existing causes of morbidity and mortality? What's the demographics? What are other health surveys that have been done? And satellite imagery, trying to get a rough indication. Field assessments can be conducted in the first couple of weeks to really understand the actual needs, but from quite a general perspective, and it should be ideally multi-sectoral. And then more health-specific assessments can then come in from about week 3 onwards, including the sort of random sampling of population surveys, surveillance systems, to look at the needs that are being identified by the affected communities themselves. And we need to trying to establish the disease surveillance systems to be up and running as soon as we can following a crisis, in order to detect the changes in mortality and morbidity and potential disease outbreaks that we saw in the previous graphs. We need the disease surveillance systems as available and strong as we can, as early as possible in a crisis, so that we can really get our eyes on the ground and know what's going on in order that we can respond to it with the information, with the evidence. So there are a number of assessment methods. So this is a slide from the reading pack, and so it lists a huge range of assessment methods for different health topics. So these are all available to you. So mortality, communicable, non-communicable diseases, WASH, nutrition, sexual and reproductive health, mental health, injury and health service availability. So all of those are available and in the reading pack. So often following a crisis, it's really difficult to actually sort out the wood from the trees. The situation, every crisis I've been involved in is a mess. Everyone is running everywhere, everyone is shouting that this thing is the priority, or that thing is the priority, and frequently we see it's the loudest voice that gets the priority. How do we avoid that? How do we avoid responding to who shouts loudest gets the money? Well, actually, I'd recommend taking the technique of feeling an elephant. So there's a story from India about, I think 6 blind men were feeding an elephant. And one man was feeling the elephant's tail and saying, oh, it's skinny and it's got a little hairy bit at the end. And another man was feeling the feet, and he was saying, oh, it's big and it's got these funny large nails at the end and it's just very heavy. And another one was feeling the trunk and was like, oh, it's really funny, it's got 2 holes and it's waggly and it's wrapping around me. Another one was the ear. So, and you can see the analogy. And actually, the only way 6 blind men could actually understand the elephant was to talk to each other and to work out what are the multidimensional aspects of an elephant. So what's the big picture? We need to do the same with a health system. Within a health system, I'd recommend using, and this is a 5-minute exercise, and every crisis I've been involved in, I just do this 5-minute exercise for myself. And actually, even if it's a chronic crisis, or even in a context like DRC or Somalia, when actually I'm finding myself in a bit of a grey, in a bit of a maze, I'll still go back to this 5-minute table and framework. I simply write down 6 building blocks down the x-axis of the y-axis of the table, and I also include community interface, just to make sure that we because it's so important in crises looking at the community aspects. And then I do 3 columns. What was the situation before the crisis? This is critically important because actually the situation before the crisis is a critical determinant of how we respond. So how strong was the health system? Where were there weaknesses and strengths within the health workforce? So for example, we saw a situation with Haiti where we had a lot of quite well qualified doctors and nurses. We saw a situation in Zimbabwe which was the same. A lot of the older health staff were incredibly experienced and were very possible to work with. But other contexts, in Libya, you'll see a lot of doctors, but actually no nurses, because all of the nurses were from the neighbouring countries and so returned back. So you need to be aware, what are the pre-existing situations of the health system? And then what was the impact of the crisis? Where did it have its specific impact? Like we saw with the Ministry of Health in Haiti, the complete disruption of the health information system. And therefore, that using the pre-crisis and the impact of the crisis, we can then fill in the last boxes, the last column, which is what's our initial response? How should we be responding in this area? And this just helps us to be able to take account of each health system building block and to sort of try and take a holistic view, make sure that we don't miss anything. Because we frequently, in a crisis, even if we're a long-toothed health advisor that's been involved in many countries, we'll forget things. We'll get focused on the thing that's the most obvious, and actually just a reminder, a tool to help us to go back. So I was filling this out for Haiti. So this is what I'd filled out earlier. So for example, in Haiti, we had a well-functioning warehouse. We had well-trained health workforce. There was direct cost sharing with user fees that were limiting access to health services. Only half the population had healthcare. And then what we saw, the impact of the crisis, the impact on leadership and governance. The Ministry of Health lost 200 staff. Many health staff left their posts. Decimation of the Ministry of Health systems, and therefore some of the only systems that were available were private systems. Facilities destroyed, people living in camps. So, and therefore you could plan a tailored response. And in terms of the specific health technical guidance, there is a plethora of guidance for different topics in emergencies. And so all of these are in the reading pack. So there's a full table, and you'll find it on communicable disease, nutrition, WASH, sexual and reproductive health, mental health, non-communicable diseases, injury, health systems and services. So this is just a whole plethora of different guidelines which are available to you depending on the topic. So, next one is how do we reduce the length of the snake? So this is the R word, which I think a lot of us struggle with, resilient. We just need to find a better word or design a better word for what this is. But so this is some of the evidence from, again, a literature review on resilience that was done by Dave Gonalog, one of the public health registrars. So this is, he conducted a systematic literature review with colleagues on this area. So, and this is also taken from some examples that we've seen in contexts in DfID. So we need to have flexibility in design, the ability for programs to adapt to specific contexts. And this is talking about resilience in, and when we're talking about health, I think about it two ways. One is resilience in systems, but also the resilience in our health programs. So it needs to be both. They need to be flexible. They need to be able to adjust to this changing context. I often call this a chameleon approach. This is the way I see it rather than resilience. It's actually being a chameleon. It's being able to adapt our colour of our health program or our health system to the context. And we need to be more chameleon-like and more fragile the context. A country like South Sudan is completely chameleon. You're constantly going from context to changing context to changing context. And you can predict the unpredictable. We need the ability for health programs to work both inside government systems and outside government systems. The ability of a system to learn, and we don't. Floods in South Sudan is a classic. Everyone's surprised. Everyone fails to sort of put the stocks in some of the flood-affected areas before the rainy season. So we need to learn. That's not brain surgery, but actually we're often surprised by the regular. Also, a critical element of resilience is a population social capital and cohesion. How, before a crisis, how cohesive was the population? And how able are they as a community, as a population, to respond in a unified way to unexpected disturbances, to support participation and communication in crisis? What were the pre-existing networks? Strong pre-existing networks, both within the country but also internationally, are particularly useful. One of the things that we found within research and responding to the Ebola crisis, the reason we were able to respond faster was there were pre-established networks of funders that could use funding mechanisms to respond. So it's the pre-established networks, whether it's response or research or in-country or international. What is a resilient health system? I think we need to learn more about this. There are some obvious things. I think resilience is different from a strong health system. So a classic example of that is a paper-based system in Haiti, which just wasn't resilient to earthquakes. But actually, we need to differentiate what is resilience, and what is strengthening health systems. And one of the things we hope to do more research on is actually building the evidence on what does it mean, what does make up a resilient health system, what interventions can make a health system and health programs more resilient. We need a strong early warning surveillance and disease system to be able to predict and respond to outbreaks of communicable disease is important for resilience. And also, one of the critical elements of resilience is a community members that have the capacity and resources to be the first to respond when a disaster strikes. And that's some of the strongest evidence is around the role of communities in being resilient to crises. So the next topic are the ladders. So where are the opportunities that we see? And actually, there are opportunities for health system reform coming out of crisis. We need to be aware of it. The classic example for this is the NHS. So the NHS, the original planning for the NHS took place in 1942. During the Second World War. The white paper for the NHS went through in 1944. So actually, a lot of people would say that we would not have the NHS if it wasn't for the Second World War. The UK took the opportunity of the Second World War to establish a strong public health system and a strong system within the NHS. And whilst that is quite an extreme example, it really shows that actually there is this opportunity for quite significant public health reform that crises bring. And it's general health, and the literature on this is again taken from a literature review, shows it related to general health system reform. There is opportunity for reprioritisation of health policies. For example, if mental health was a neglected area, a lot of literature shows it's possible to really sort of focus on it and really bring up these neglected areas in crises. And it can also lead to better information that's available for planning. And the reform is most effective when it's planned, like the NHS, when it's planned during a crisis, often a small group of people coming together, the right people, the small group of people with government coming together and planning for when the crisis finishes, and then implemented towards the end of the crisis or early on after the crisis. And there is a small window of opportunity which is lost, which can be lost. So people move on. People are less, after about 6 months, or depending on the type of crisis and the magnitude of the crisis, people lose the momentum. People lose the willingness to change. And so you need to take the windows of opportunity that are available. And it's also limiting the damage that our responses can cause, making sure that our humanitarian responses take account of the existing systems, take account of the community, take account of the national organisations that exist and the local capacities. So moving on from resilience, one of the reading packs is about the sort of principles and conventions that exist within humanitarian. So I'm just going to make you aware of them. There are core humanitarian principles of humanity, impartiality, neutrality, and independence that are the sort of bedrocks of the way that humanitarian work is done. And linked to this, there's the Geneva Convention associated protocols. So the Geneva Convention regulates the conduct of international armed conflict. And actually international humanitarian law, which is specific for it is specific for international armed conflict. And some of the grey areas with international humanitarian law is actually internal civil conflict within a country where there aren't international partners. Actually, is one of the grey areas and is one of the challenges with international humanitarian law. The ground rules, which is the principle respective to international humanitarian law, good humanitarian donorship, the Red Cross Code of Conduct, sphere guidelines, which provide the sort of technical guidance, and the principles of accountability to beneficiaries. So looking at this general humanitarian system, so there are 11 clusters that occur at the global level and at the country level, and this lists them all. I'm not going to go through them, but there is a lead agency at the global level. It doesn't necessarily need to be the same lead agency at the country level, but it often is. And there are roles and responsibilities. There's a humanitarian coordinator that's responsible that's based in Archer and often responsible for overseeing all of the different clusters, and each cluster lead will report into the humanitarian coordinator. There'll be the health cluster coordinator, who is responsible for the health cluster, this group of partnership. It's the partnership and the group of organisations that make up the health cluster. And it's interesting because actually the health cluster coordinator, although often working for WHO, is actually responsible for the partners that are available outside WHO. And then WHO, although the lead for the health cluster is almost wearing two hats. It's a lead for establishing this coordination mechanism, but it's also a lead for the WHO action in response to the crisis as well. And often that gets mixed up. Is often we will sort of confuse their role of coordinator from their role as responding as an agency, and the role of that relation to government. There are also emergency medical teams, which are these groups, for example, trauma teams responding to crises. We have the Global Outbreak and Response Network, and the incident management system is a new system that's been brought in. An incident management system is in a major crisis. There'll be an incident manager that actually often will take over responsibility and leadership for responding to a crisis, often taking on this responsibility of overall command and control, as it were, because the incident management system is moving in the direction of command and control rather than coordination, but actually take on the responsibility for the oversight of it. So a few updates on WHO and emergencies. So I was in the Global Health Cluster last week, so this is some of the things that are being discussed on Thursday and Friday. So WHO has moved from having quite a separation between their work on outbreaks and disease surveillance from humanitarian crisis, and actually now is taking an all-hazards approach. So all hazards mean natural disaster, conflict, outbreaks. And in outbreaks, the WHO provides strategic leadership, and OCHA is supporting the operational coordination. As I said, they brought in the incident management system. There's an increased focus on WHO away from being a sort of normative and technical agency to being operational. And I think we'll see what that looks like in the future crises. We have a new, in Geneva, but also in the regional offices and in country offices, WHO has established a new humanitarian system, with 5 divisions of labour working from sort of preparedness right up to response. So the 5 divisions that they've put within their teams are the 5 divisions of the way we respond to humanitarian crises. And there's one ADG that's been appointed to oversee this whole new humanitarian structure, which is Peter Salama. So it was announced yesterday that he's been appointed. But what's still to be done? I think WHO would probably, it's fair to say, they've not given sufficient thought to how coordination works across mechanisms. How does GO1 link with the emergency teams? Links with the global health cluster? Better thinking on partnership. Whilst there's been a lot of focus on reform of WHO and emergencies, they haven't really looked at outside WHO and how they work within a much greater, wider humanitarian system that involves many players that won't necessarily be part of these coordination mechanisms. Organisations like MSF and ICRC that are some of the bedrocks of responses to humanitarian health. We need to be better at thinking about protracted crises. A lot of the tools and the way of working within cluster approach is specific to that context. We need to be much better at thinking through the complexity of how we respond to protracted crises. And we're waiting to see how this is implemented in the next crisis. So humanitarian updates. There was the World Humanitarian Summit a couple of weeks ago. What did we see coming out of that? There's the Grand Bargain, which brings transparency, increased focus on use of local and national aid agencies. We need to be using cash, and we need to, there's work in WHO thinking, what are the implications of this for health? In crises, how should we be using cash for health and for public health outcomes? Reducing duplication management costs, streamlining assessments, multi-year planning and funding, which DfID has been one of the sort of the innovators of multi-year humanitarian programs. Sort of reducing earmarking, harmonising reporting, and a lot of talk about humanitarian development. So humanitarian space is increasingly complex and challenging. And we see this sort of balance of service delivery, stabilisation, state building and system strengthening. And looking at new ways of operating within DfID, we've seen the book Dull Disasters. How do we operate in protracted crisis? How do we operate in protracted displacement that we're seeing in Syria? And the humanitarian development bridge was a major topic in the World Humanitarian Summit. And how do we look at that? And so with this humanitarian development bridging, so some of these diagrams just show the complexity that we have. And it's not, we don't have two groups of area, which is humanitarian development. It's a continuum from humanitarian relief. If you look at the diagram on the right, it's the continuum from humanitarian relief at the bottom left to sustainable development. So increasingly moving from service delivery to system strengthening. Increasingly moving from government bypass to government partnership. So one of the things in the Humanitarian Advisors CPD meeting last week is I was saying we need to be as development focused as possible, but as humanitarian responsive as necessary. So we need to be maximising our work on development whilst acknowledging a critical component of saving lives and reducing suffering is humanitarian responses. Some of the challenges I gave to the humanitarian advisors at the CPD meeting was what can be done through development programs, actually what shouldn't be done by humanitarian, and things like health service delivery, CMAP. So I think there are some things that if we see them done using humanitarian funding, actually we should say that's a failure of the system. We should be building these in to the way that we do development programs because we should be part of resilience. We should be predicting these crises. And humanitarians should be taking opportunities to strengthen systems through the crisis. The challenges for the health advisors, I think we need to be looking much more about resilience of programs and systems and ensure that these are aware of the likely crisis and mitigating these. I hear a lot of talk about resilience from humanitarian colleagues. I don't hear so much talk about resilience from health colleagues, and I think we really, or other development colleagues, and we need to address that. And also the flexibility of programs. We need to look at not just programs that work with government, but programs that work with government and non-government. Programs that work with system strengthening and service delivery. We need to be organisations that can work in both of these contexts, because we need to be able to work and adapt. And to do that, we need to be happy working, and both as DfID, but also the people we're funding, happy working in both contexts. So a quick overview of the resources that are available if you're feeling a bit stuck, like this is my car getting stuck around South Sudan. So what do we have available? There's various humanitarian guidance notes. So there's cholera, gender-based violence, mental health emergencies, and reproductive health emergencies. There are the 2 reading packs, which I think will probably have a link to this presentation, so you'll be able to see that. But lots of other resources out there. And there is a training available. There's the humanitarian health training, which Save the Children will be running 2 courses starting in September 2016 and June 2017. And you can either go on the full course or attend specific sessions. And there are a number of other courses that are available as well. So the DfID for rapid response has a UK emergency medical team and the UK International Emergency Registers. So these are available at DfID's disposal, often used in rapid onset crises. And what else is going on? So this is the last slide. There's research. We have the evidence review on humanitarian public health, which is due to be published in Lancet and is available on the ALRA website, which is the full literature review of all evidence on humanitarian public health. We have R2HC, Research for Health and Humanitarian Crises, which is the funding mechanism funded by DfID and Wellcome for research in this area. We have, so within the Ross Fund, we're going to be looking at some elements of epidemic research, the WHO blueprint, development of diagnostics for epidemics, epidemic research and health systems resilience. We've got Rebuild, looking at research in post-conflict situations, and also Department of Health is looking at vaccines for epidemics and rapid response teams. A lot of work looking at the policy aspects of reform of WHO emergencies and global health security. And programs, a number of existing programs looking at disease surveillance in West Africa, the Syria Health Strategy, which is a critical strategy, looking at how do we do development in a very protracted crisis. And that would be very interesting to see how that progresses. Humanitarian programs that include health, and health programs that are in humanitarian context, as many of our health programs are. And we're seeing outbreaks as well, which are sort of, again, leading us into various sort of crisis thinking. Zika, yellow fever, after Ebola a couple of years ago.